So the updates for Polycythemia Vera in 2025 comes from the current national guidelines of therapies that I've summarized here for high-risk patients, as I said, age over 60 or having a previous blood clot. But even for low-risk patients, that would be patients that would not fit into that category, but would, for example, have uncontrolled blood counts and need frequent phlebotomies, oral hydroxyurea, which is standard chemotherapeutic agent used for years, or injectable raw-PEG interferon, which is the novel pegylated interferon extended profile, would be a preferred frontline choices. Suggested alternative would be pegylated interferon, which is also an interferon being used for years for myeloproliferative neoplasms. It is just a little bit more frequent injection. In a second line setting for this patient, that means if the first therapy either doesn't work or fails, oral ruxolitinib, which is the JAK inhibitor that I just mentioned for myelofibrosis, is approved for these patients. And then again, the previously used in the frontline setting, injectable raw-PEG interferon versus pegylated interferon or oral hydroxyurea. So raw-PEG interferon has been the latest and actually the only recent approval and the only interferon approved in the space for patients with MPN and specifically for polycythemia vera. That was approved in November of 2021 by the FDA for the United States use, based on the data of high-risk patients. But there are also data from what we call low PV study that emerged recently and already had a very solid 24 months follow-up, where basically in both of these categories, raw-PEG interferon induced superior control of blood counts, basically led and showed to have less progression to myelofibrosis as well as thrombosis, which is one of the major endpoints the previous therapies were not able to achieve, and more importantly, reduce the JAK2 allele burden. As I said, polycythemia vera in 96% of patients would be defined by the standard JAK2 V617F mutations, and reduction of this burden has been shown to be achieved in majority of patients on raw-PEG interferon, hopefully showing us a way to deeper control the disease and maybe lead to better disease stop or progression. The latest development on top of this, it's approach that is basically called hepcidin mimetic, which is a specific drug or a class of agents that will be very likely explored in this area in the coming years, and that address hepcidin as a major regulator or hormones that regulates an iron metabolism. Polycythemia vera patients have unregulated iron that is being excessive for red cell production. That's why they suffer with excessive red cells in their blood and all the disease consequences. Therefore, mimicking hepcidin, which could lower the iron access to erythropoiesis and block it, the first agent being explored called rusfertide, makes sense to improve upon phlebotomy dependency and also iron redistribution for these patients. Standard approach for polycythemia vera phlebotomies that's been used over and over the decades to decrease the hematocrit below 45 is helping or preventing the thrombotic complication that has been shown by the hallmark studies and define the national guidelines. But however, comes with some burdens. That means people have to come for phlebotomies. They have to have the blood removed. They could have a dizziness, other side effects. They need to get the needles in. They could get a volume shifts. They become more and more iron deficient on top of what polycythemia vera would normally do. And iron deficiency has additional adverse effects on the human bodies. Therefore, having an agent that could mimic or improve upon iron metabolism makes a lot of excitement. And we had the first data that were presented in 2025 of this first in-class agent named rusfertide. It's a little complicated name, but nevertheless, it has finished phase 3, which is the latest study that could go for the approval that basically randomized patients to either edit rusfertide, it is injectable weekly agent, or whatever patients were doing and placebo in PV patients that would be dependent on phlebotomy with the goal, can we eliminate the phlebotomy needs? And the study has met all of its endpoints, where the primary endpoints, that means the primary reason the study was conducted and to show what superior control of phlebotomy needs, that was achieved in 77% of patients versus only 33% of those that continued the originally placebo randomized approach. And then other approaches or other endpoints called secondary endpoints, they were equally relevant, but not done as a primary in the study, were also met. That included sustained control of the hematocrit, so it would not go over the 45 in 63% of patients versus only 14% on the control arm, and then significantly improved symptoms. So here we come into quality of life, which is a very significant clinical endpoints for our patients. Again, as I mentioned, this is a novel approach. The hepcidin mimetics, or a different way of altering iron metabolism, are entering clinical trials in polycythemia vera patients, and very likely will represent a novel approach to either add on to current therapies, somehow combine, or only present for patients with otherwise low-risk disease that would not tolerate phlebotomies and don't have to have them that frequently.